with Implant Compare, about to start an exciting series on nerve repair. Last week, I talked about the importance of actually visualizing the inferior alveolar nerve and the lingual nerve. So, as an oral maxillofacial surgeon, I'm looking at photos of an inferior alveolar nerve. And the reason why I wanted to do this lecture series is because I know a lot of general practitioners don't have the opportunity to actually see the nerve live. So I think this is very exciting. The other thing is there's a lot of new information out there on kind of what can cause nerve damage. So the first part of the lecture will be on nerve anatomy. The second part of this series will be on this particular case, which involves the inferior alveolar nerve damage with repair. And then we'll finish up with part 3 on a very similar issue, but that involved the lingual nerve. So our duty is to spread knowledge globally through Implant Compare, which makes it a lot easier. So I will continue with part 1 in terms of where are these nerves anyway. And of course, I got to give a big shout out to Implant Compare. They are doing big things in our industry, which is very exciting. So thank you again for giving me the opportunity. So let's talk about oral nerve anatomy. This is something that all of us as practitioners, whether dental hygiene, dental assistants, general practitioners, specialists, we all deal with these nerves, and I think it's good to have a little refresher. So we'll discuss the inferior alveolar nerve. So I'm looking at this diagram here, and I know it might be a little bit confusing, but let's focus on a couple things that I'll highlight in red. So first, we have the mandibular nerve, which we all know is a third branch of the trigeminal nerve, or cranial nerve 5. It then gives off a branch called the lingual nerve, which I'll discuss shortly. We also have a nerve to the mylohyoid that a lot of people aren't familiar with. This actually provides motor function to the mylohyoid into the anterior belly of the digastric. And this branch occurs right before the inferior alveolar nerve actually goes into the foramen. Next, we have, I'm looking at the screen here, the inferior alveolar nerve itself, and it's called that when it gets into the canal. And then we have these little complex nerve distributions that are called inferior dental nerves that actually provide those little plexus of nerves to the dentition. And then as it leaves the mental foramen, it is called the mental nerve. So to look a little closely at this is the medial portion of the mandible. So we have the vertical portion of the mandible is called the ramus. And this is where the inferior alveolar nerve gives its branch to the mylohyoid before the nerve dives into the canal. The red is called the lingula, and the white is the mandibular foramen. So this is our landmark when we inject anesthetic for a block, is to be kind of where that lingula is and above the mandibular canal, because then the nerve you can block the nerve conduction. So this is a schematic of the actual of what's going on inside the jawbone itself. So the long portion of the mandible, we call that the body. So the inferior alveolar nerve does supply the mandibular molars and part of the second premolar. We then have these sensory branches called inferior dental nerves, or a plexus, that provides the sensation to the gingiva and the teeth themselves. And once the inferior alveolar nerve leaves the mandible or leaves the jaw, it comes out of foramen called the mental foramen, and then this is where it's called the mental nerve. And this provides sensation to the chin and lower lip. A lot of people aren't familiar with this next portion. So when the inferior alveolar nerve leaves the mental foramen, there are still nerves that go through the symphysis or the chin area inside the jawbone. This is actually called the incisive nerve, or what they call the incisive branch, and that nerve is in the jawbone through the incisive canal. So what a lot of people aren't familiar with is that if you're going to place implants in the mandibular anterior region, you have to watch out for this nerve, because if your implants impinge on that incisive branch or that canal, you'll cause sensation changes in the anterior, and it's really hard to see this canal on films, but it's there. So let's talk about the nerve function for the inferior alveolar nerve. So in terms of sensory, we have the area here. So the area in the yellow is with the mental foramen. We know that it provides anesthesia for the mandibular molars that I'm looking at, the premolars, and the incisors. It does provide, when you do a block, it does provide anesthesia to the tongue, which we'll discuss via the lingual nerve. And then what people need to understand is this block does provide numbness to the bone itself. So that's the reason why any surgical procedure, you'll never be able to fully anesthetize the area without giving a block, because that nerve is what blocks the bone. The other thing too is there's a portion on this cartoon or this diagram that is not highlighted. And what we have to understand is that is due to the long buccal nerve, which we obviously anesthetize also to get and capture the gingival mucosa in the molar region. So for the motor, a lot of people don't know this, but this is a good review, is that mylohyoid nerve supplies the mylohyoid, which basically is the floor of your mouth, and then the anterior belly of the digastric. So this is just some good test fodder if you're a dental student, or this is just a good memory. So let's talk about the lingual nerve here. So going back to our diagram, our lingual nerve is here, which does branch from the mandibular division of cranial nerve 5, or the trigeminal nerve. I do like this schematic. It starts to show that the lingual nerve passes on the medial portion, or on the inside portion of the ramus. And what we'll see is that this lingual nerve actually comes pretty close to where the wisdom tooth would be. So this is a famous study done by Dr. Chamberlain and Kasselbach. These are famous names in oral maxillofacial surgery, coming out of the Journal of Oral Maxillofacial Surgery, which is our proud journal. So this is looking at the clinical and anatomical observations of the relationship of the lingual nerve to the mandibular third region. So what they did is they looked at 34 cadaver dissections in about 256 cases where third molars would be extracted. And this is what we need to pay attention to, because this is what's causing our nerve injuries, is that 18% of these dissections actually had the lingual nerve at the level of the crest of where we're doing our surgery. 62% actually had the lingual nerve contacting the lingual plate in the third molar region. So any of you all, surgeons, general practitioners, if you're doing third molar or wisdom tooth surgery and you perf that lingual plate, you perforate with your burr, you may have touched that lingual nerve and you just now caused your patient issues. So this is why I'm giving us the information, because as a general practitioner doing this type of surgery, you got to be careful, because if you don't know your complications, it's not fair for the patient to undergo surgery with you. Of the 256 patients, the nerve was visualized to be above the height of the lingual plate in about 4%. I prefer looking at the 62% and the 18%. So let's look at the lingual nerve function. So the lingual nerve provides sensory to the anterior tongue. And what a lot of practitioners don't understand is Imagine you have a numb tongue, or you caused your patient to have a numb tongue. This will change the quality of their life. And I think that this is why I want to bring this to our attention, because again, if you're going to be doing these surgeries, you need to understand the complications. Otherwise, it's not fair to the patient, ethically and morally. So what causes this etiology? So it's actually our fault. Okay, we need to accept that. This is our fault. It's not the patient's fault. It's our fault because we either don't know the anatomy or we're being too overzealous with our hand pieces. This is our fault and we need to accept it and change. So, one of the most common things that happen is wisdom teeth removal. I'll go through a portion of this list, but we'll start with wisdom tooth. All right. So I just grabbed this off the internet. This is not my case. This is probably a typical incision made for wisdom tooth surgery. I prefer this one, okay? Let's pay attention. This white dotted line is where the incision is on my left side of the screen. We are extremely medial than where we should be, okay? Because we need to know that 60% of the time this lingual nerve is actually touching the plate. So the more medial we are, the worse we are of injuring this nerve. This next dotted line is how I was trained to do this. We make our incisions away from the lingual plate. Now you can see we're nowhere close to the lingual nerve. And this is best illustrated here, okay? This is a medical illustration of the lingual nerve being damaged because of our incision pattern. This is another problem. Practitioners don't understand why we make these certain flap designs. Well, this is the reason, okay? So look at this. If we make our incision the way that I was trained and the way that I'm telling you all to do this in terms of having it come out more buccal, we're away from the nerve. There is a reason why we do this flap design, okay? So again, if you're going to do wisdom tooth surgery and you have poor flap design, you are causing the problem for the patient. And this is why we're having this lecture, so we can inform everyone and do a better job, even on our end. Sectioning mandibular molars, another common thing. So we see here, this is an orthopanogram of medium quality, but here the important thing is we can see the canal. So the canal is highlighted in the black arrows. This is a case of mine that I'm going to present. This was not my case, but I oversaw the case where a general practitioner had caused inferior alveolar nerve injury secondary to sectioning a mandibular molar. So this is where they attempted to section the mandibular molar here. I've outlined the canal in white. We need to understand that these are the irregularities of the canal. It's not this nice smooth tunnel. Things are changing. And what happened is they took a burr and they disrupted the canal, okay? And what had happened is they noticed bleeding. I'll go more into this at part 2 of my lecture series, but this is common. We have to be careful. Dental implant placement. I can't stress this enough. Everyone's doing implants. I'm okay with that. I don't care. There are 7 billion people on this planet. Implants for everyone. However, if you're going to do implants, you need to be cautious of this because you're causing injury to a patient and you're a doctor and you need to know this. This is a good example. They had placed the pilot drill or the drill sequence, then taken a film to show that they're still 2 millimeters above the canal. This is another good example showing, these are all online, these aren't my cases, that they're still maintaining the distance from the inferior portion of the implant to the canal. You can also see that the last implant here they had drilled, because you can see the radiolucency, and then they backed out. So this is important. The other thing is with the mental foramen, we have the anterior loop, right? You gotta stay 2 millimeters from any portion of the nerve, and we all know that with this anterior loop of the mental nerve, it can sometimes be 5 to 7 millimeters anterior. You gotta know this. This is very powerful. We need to understand together. Excuse me. So what happened is, this is a medical illustration showing the 5 types of damage we can cause on the nerve. Part 1. This is where we have our drill sequence with the implant. What happens is you go down too far, even though your implant is 2 millimeters from the canal. Well, what happened is when you did your pilot drills and you did your sequence osteotomies, you obliterated or compromised the canal. You've already caused trauma, even though the actual implant is away. You gotta be careful about that. Second thing is, you've completely taken the implant drill through the canal and you've actually transected the nerve. C, you have partial, this is interesting, this is the case that I'm going to talk about next week. Is the general practitioner took a drill, it wasn't an implant, went through a part of the canal, but the nerve bundle, the neurovascular bundle was compromised, started to bleed. Well, you can cause a hematoma, and that pressure causes secondary ischemia to the nerve. D, thermal stimuli. If you aren't using irrigation, you are causing so much damage. So the nerve can actually have damage due to the thermal stimuli. And then E is when you actually have primary damage to the nerve secondary to stimuli, thermal. This is why we use irrigation, to prevent bone necrosis. And then this is something that a lot of people aren't familiar with, and this is why I want to bring this up, is actually there is some talk of local anesthetic causing neurotoxicity, okay? So the 2 common ones that we use in the US is xylocaine 2% and septocaine or articaine 4%. Now that 2% and that 4% is when I'm looking here is the concentration. So when it has 4%, it means 40 milligrams. 2% means 20 milligrams. So articaine and septocaine at 4% have a higher concentration. This is a study that Peggerell did in 2007. Looked at a couple cases of anesthetic. So what we see here is lidocaine caused about 35% of damage or nerve damage in this particular study. Articaine was only 30, so they're kind of comparable. This is another study that was done by Gaffin and Haas out of 2009, where they looked at paresthesias. So if we look on the right side of this graph of this table, articaine caused about 60%, whereas lidocaine only caused about 13%. So what we're starting to see is that there can be issues with the lidocaine you choose. However, I'm about to show you another study that says that lidocaine and articaine are very similar, and so we don't necessarily have full scientific literature supporting this. However, these are things that we need to be cognizant of. So Malmed, who's a famous practitioner, said that basically they are comparable. They were looking at articaine 4% and lidocaine 2%. And they basically showed that the frequency of paresthesia is less than 1% in both treatment groups. Now, they did not offer any hint at what articaine might be associated with, but they did say that lidocaine and or articaine is good. One last thing to kind of mention regarding this If your patient jumps out of the chair because your needle has hit the nerve, we like to congratulate ourselves because we're like, we know that that patient's going to get numb. But what you don't understand is that needle hitting the nerve actually caused nerve damage. So this is for nerve damage. We are looking at three types of sheaths or coverings in nerves. We have the epineurium, the perineurium, and the endoneurium. This is common for every nerve, central, peripheral. We have a classification system in oral maxillofacial surgery called the SEDDON classification. It is used all over the body, but these are things that you're going to want to know just from a general practitioner standpoint. So when you do talk to your oral surgeon, you actually can have a cohesive conversation. So this is a medical illustration showing the three types of classifications for the SEDDON classification system. Neuropraxia. You actually have injury to the conduction deficit, but all three of those layers are still intact and you can have spontaneous healing. Axotomesis. Axotomesis is where you actually have injury to the epineurium, but the endoneurium and the perineurium sheaths are still intact and you do still have potential for full recovery. Neurotomesis, this is the worst. Neurotomesis means that you've actually caused disruption of all three sheaths, and this is where microsurgical repair comes into play. Another classification system that we use is called the Sunderland classification. This is more complex. I will not go into this. So SEDDON and Sunderland classifications. SEDDON classification is the most important that we use. Nerve testing. Mapping the area of altered sensation. So what we do is we basically map or draw a diagram on the patient's face of where the altered sensation is. There are three types of level testing. We have level A, level B, level C. So level A is we're trying to determine a certain type of fiber or nerve fiber. This is called a 2-point discrimination test. What we do is we take calipers to touch the skin when the patient's eyes are closed, and we're basically trying to reduce that distance of the two calibers to as small as possible to say when the patient knows that they can feel 1 point. So we're trying to determine at what distance they feel it at 2 points, and then when those 2 points feel like 1 point. The second test that we use within level A testing is called a brush stroke directional test. This is where we take a little brush and we do these brush strokes to determine if we're going left or right or up and down, and the patient is still, their eyes are closed. So we're basically trying to figure out what type of stimuli is delivered by the brush. Again, this is touching a little different type of nerve fiber. This is gathering us data on whether or not the nerve injury is permanent, if it's being reversed spontaneously or not. Level B testing. Level B testing is called a contact detection test. We're trying to test another type of fiber. So basically what we have is we have these plastic ends with it looks like a horsehair, like a thickened horsehair that will bend on a certain force contact. So this is what they're called here. So what happens is that each thickness of this filament will bend on a certain force, and you just lightly touch these areas with the patient's eyes closed, and then it correlates to a certain thickness of the fiber and the force. Level C testing is a sharp, blunt discrimination test. Again, we're trying to find out a different type of fiber here. So you're going to randomly touch the patient with a sharp or a blunt end, and the patient will either say, ouch, or I can't feel that. The last thing that is done is a thermal test. A thermal test is looking at another type of fiber, nerve fiber. where you take 2 glass tubes, one warm, one cold, and then you basically decide, or the patient decides on which they feel. This is what's critical as I start to finish up. Now, as a general practitioner, I don't expect you all to do this type of nerve testing, but you need to understand what we do at our consultations appointment, because you need to be informed, because you're taking care of the patient too. And I think it's naive to not understand this, especially when you're taking care of patients, because it's our duty as practitioners. Timing is key, okay? They talk about getting this patient to us in 3 months. What happens all the time is, one, no one wants to admit they messed up. We're not going to judge you. We'd rather you be honest. Second, practitioners will wait 4 or 5 months just to see if it spontaneously resolves, and you don't have the information to back that up. So that by the time the patient gets to us, if we were to do surgical repair, it's too late, because as a practitioner, you all weren't able to say, hey, I messed up, I'm going to get you to a surgeon as soon as possible. Again, as a maxillofacial surgeon, we're here to help you. We're not going to judge, but if you mistreat a patient, that's when it's a problem. The second part of this series is going to be about the inferior alveolar nerve. And again, I love the idea of spreading this globally. I'm a maxillofacial surgeon. You can contact me at any time to ask me questions. I'm here to help. Other maxillofacial surgeons need to do the same. We are one family because we're cut from the same fabric, aka dentistry. It's important, though, that you need to treat the patient as if it were your family. If you transected a nerve, or if your mom or sibling had a nerve injury day one, I guarantee they would be in an oral maxillofacial surgeon's practice the next day. What you all don't understand, because you don't see this, is the quality of life is jeopardized significantly. These patients can't feel their lips. They bite their tongue constantly. This is an awful thing to happen, and it's our fault. So this is a photo of the nerve that I showed at the beginning of the case. This is taken through a microscope, which is extremely cool, one of the most fascinating things of residency. But please stay tuned for part 2 of the series, Inferior Alveolar Nerve Injury and Repair. Thank you again for Implant Compare sponsoring this event. My name is Dr. Matt Koepke. You can find me all over social media. These lectures are fantastic. I've purposely kept them to be about 20-30 minutes, but this is something that we could obviously talk about at a conference in person for 1 to 2 hours if anyone's excited or interested. So thanks again, everyone. Take care. Dr. Matt Koepke here, coming live from Sydney, Australia. It's actually 3 a.m. There's a 13-hour difference between New South Wales and Eastern Standard Time. So I actually have downtown Sydney behind me, so I'm super excited to present part 2 of 3 of the trilogy series involving nerve repair, nerve damage and repair. So again, thank you so much, Implant Compare, for giving me an opportunity, even tens of thousands of miles all the way across the world, to continue this webinar series. So thank you. I wanted to review part 1, the nerve anatomy and damage etiology. So from the last lecture, we got really good feedback, because a lot of general dentists, they weren't aware of what's going on. So this is the whole point of these webinars, which is I'm excited to continue. So with the inferior alveolar nerve, we have sensory and motor in regards to that nerve in particular. So when we give a block, we anesthetize certain areas of the mandible along with the gingiva and tongue. A lot of people aren't aware that it has a motor component as well. So it does supply the mylohyoid and the anterior digastric via the mylohyoid nerve, and it gives off that branch before the nerve goes into the canal. The lingual nerve gives sensation to the tongue. It has no motor components. And we also discussed about our flap design. I think this is one of the most critical parts of part one of the trilogy. So here in this clinical photo, we have an incision that was made that's illustrated by the dotted white line. I believe that this is too far medial because we can have the disturbance of the lingual nerve. This clinical photo on the right is better. We can see how the incision is more lateral into the buccal tissue. One of the caveats that we learned in surgery residency is angulating our incision to avoid the lingual nerve. So we can see here in the medical illustration in the center that this incision, because it's too far posterior and medial, you can compromise the lingual nerve, which will then anesthetize the anterior tongue. So this is where, with that angulated incision, we can avoid damaging the lingual nerve. So again, if you're a general practitioner extracting wisdom teeth, that's fantastic. Just be aware to make sure that you do angulate, or what's called a hockey stick incision, to avoid damage of the lingual nerve. Here we also talked about the importance of imaging and staying 2 millimeters away from the anterior loop of the mental nerve, and 2 millimeters away from the superior portion of the inferior alveolar canal. This is a medical illustration showing the 5 different ways that we can actually do damage to the inferior alveolar nerve canal. This is a cross section of a mandible, and that circle is showing us where the nerve is. And we also quickly discussed that there are certain anesthetics that could potentially cause toxicity to the inferior alveolar nerve. Again, I showed some studies that are kind of back and forth. One of the rules that we were trained on is we avoid 4% articaine or 4% septicaine in terms of blocks. So you can use septicaine and articaine when it comes to infiltrations, but try to stay away from blocks with septicaine. Here we review the nerve anatomy. So we have 3 particular layers that we're interested in. We have the epineurium, which is the outer coating, we have the perineurium, and then we have the endoneurium. Depending on which sheaths or layers are damaged, we have a classification system called SEDDON classification. So we have neuropraxia, axotomesis, and neurotomesis. So neurotomesis means that there is conduction deficits, however, all of the sheath layers are intact. With axontomesis, the epineurium, or the outer coating, has been jeopardized. Therefore, there will be some regeneration issues at that point of injury. And lastly, the most severe, we have neurotomesis. Neurotomesis means that all of the sheets are injured, and then we have to do microsurgical repair to bring 2 healthy ends together. So this is what I'll go into. So part 2 of this lecture series is inferior alveolar nerve damage and repair. I particularly like this because we had probably 4 or 5 of these cases of nerve repair in my chief year, and it was amazing to see this under a microscope. Now, my attending did all of the surgery because, as you can imagine, this is super specialized. We're underneath a microscope, but I was the one assisting and whatnot, so it was extremely exciting. Hopefully you enjoy this. So this is a case report that I experienced in my last year, my chief year of residency. So the HPI, or the history of present illness, we do have a 33-year-old Caucasian female that presented for left inferior alveolar nerve injury. Back in March 2015, FYI, I know for international dates that's 16, so this in the US we do March 2015, so I apologize. So she saw a general dentist that actually attempted to extract tooth number 18. So something very similar to what everyone does daily, right? It's just a second mandibular molar, carious fractured. And what had happened is that the dentist, while he or she was extracting the tooth, did experience brisk bleeding, which make a mental note about that. Then, after that brisk bleeding was controlled, the patient was then sent to an outside oral maxillofacial surgeon who then removed the remaining tips without further complications. So we were consulted in June 2015, so that's 3 months after injury. So again, just make note that 3 months is a long time to have a consultation for potential anesthesia or paresthesia. So again, she did have paresthesia of the left lower lip and chin since the extraction. So 3 months has gone by and now we're seeing her. She does endorse jaw pain and dysesthesia that is highly uncomfortable. She does report biting her lower lip. So here's another issue that a lot of us aren't familiar with, is that because these patients are numb, they can't feel their lip. Just like a kid, when they have anesthesia, we warn the patients in terms of not biting the tongue. So this is the same thing, whether you're a child or an adult. So this is a very serious in a quality of issue detail. So past medical history is important. She is it's relatively benign, which is good. She's a healthy 33-year-old. She does have some depression. Only past surgical history was the oral surgery that she experienced 3 months prior. She is on these medications, so Ambien, some birth control, and Lexapro. No known drug allergies. Social history negative ×3. So to review some of the radiology, she did have PAs taken. So on the left here, this is a radiographic PA of teeth number 18 and 19. We can see that there is furcation involvement of tooth number 18, and also notice that those roots are relatively close to the nerve that I'll outline in the next film. So this is what the film took. So this film on the right was taken by the outside oral maxillofacial surgeon when the patient was sent to him. So you can see that the crown had broken. The issue where that brisk bleeding encountered occurred here. We have the outline of the inferior alveolar canal, so remind you, this is not a nice smooth tunnel. There are irregularities with the canal. But what had happened is when he or she, the general dentist, used a surgical handpiece, they may have gone too deep, and that's why that brisk bleeding was encountered. Typically with brisk bleeding like that, it's hard to get that from bone, so what most likely happened is that the neurovascular bundle was jeopardized. So this is what we see. This is that medical illustration I showed you before. So we're looking at C, right? So we have a partial implant drill. In this case, it's not the implant drill, it's the surgical drill. Same concept. And it actually causes indirect trauma due to a potential hematoma. So I do believe it kind of went through the neurovascular bundle, but there was a hematoma formation in that the general dentist did place a hemostatic material that I'll go over shortly that may have caused indirect trauma to the nerve. So they did use Surgicel, which is very common, so you can use Surgicel or gel foam, but in this case Surgicel was used, and this is an oxidized regenerated cellulose. It's derived from the alpha cellulose that is plant-based. But what we need to make sure is that Surgicel is actually neurotoxic because of its acidic pH. And this is what a lot of people don't realize. So even if that little piece of Surgicel is sitting on top of the nerve, because it's so acidic, it's going to deactivate and denature some of the proteins that are along that sheath. It does absorb in 4 to 8 weeks. The other interesting thing is on microscopic view, you can actually see giant cell reactions. So that's not necessarily a good thing that you want on a nerve. Our physical exam. No acute distress, alert oriented ×3. Her extraoral exam is benign. She has maximal incisal opening of 45 millimeters. Her lateral excursive movements are within range. No lymphadenopathy. Her intraoral exam, it's a well-healed extraction site number 18. Great oral hygiene, dentition's intact. No signs of inflammation or infection. So nerve testing. Nerve testing is what we talked about last time. So this is not the same patient, but I'm using these diagrams in terms of what we did. So what we did is we did measure her distribution of paresthesia, which was 40 millimeters horizontal and 18 millimeters vertical. So imagine that same patient that you see in this clinical photo that is not her, and she has an area that is affected. We did do level A testing, so remember that this is 2-point discrimination, and what we see is interesting, but it's not surprising. So the right side, which was not affected, she could determine 2 points within 6 millimeters. On the left side, because she had that nerve injury, those two calibers had to be 18 millimeters apart before she could feel 2-point discrimination, and that shows that there is nerve injury. Level B testing. Remember, this is our contact detection. This is with those von Frey filaments, okay? They bend at a certain force applied. So the right side, again, the unaffected side, unsurprisingly, is 2.4 to 2.83. That just means that a certain amount of force or a lighter filament was able to be touched on her right side, and she was able to feel that, which is not surprising. Her left side, however, when we did the same filament testing, she required a thicker filament for it to bend so she could actually feel it as well. With level C testing, we did sharp discrimination. We did not do blunt. So the right side was appropriate detectable, and then the left side was diminished. So what we think we have here is acetomesis. So the endoneurium and the perineurium sheaths are intact. However, the epineurium has been jeopardized. There is potential for full recovery. However, she was 3 months out without any signs or symptoms of recovery. So we're going to then go to microsurgical repair. So with nerve repair, what's important is there are a lot of consultations or follow-up visits before we do surgery. We need to let her know that doing surgery does not always work as well. However, because the quality of life was so bad for her, she wanted to go to do this anyway. So we have we spend probably an hour talking about post-operative care, any potential surgical complications, so she's well educated by this point. So the date of surgery doesn't really matter in terms of the actual date. However, it was 4 months later. We have a preoperative and a postoperative diagnosis of trigeminal nerve injury, and the procedure is we explore the left inferior alveolar nerve with an external neurolysis, which just means we section the injured portion of the nerve, and then secondary neuropathy, which means we take a graft, an allograft, and then we suture it as the connector. But that's the oral maxillofacial surgical medical terms for the procedure. So you do have two approaches here. Now, this is, don't mind the braces here, but basically you have two types of approaches. We did approach A. So what we do is we do our hockey stick or our distal buccal hockey stick incision. We carry it via sulcular incision with an anterior release. We do a full thickness mucoperiosteal flap that reflects everything so we can see the cortical plate of the mandible. This case, we did not use a piezoelectric. I just found this was a beautiful photo of a lateral window on the mandible. and we remove that buccal cortical plate, and then the nerve's exposed. So what we do here is, this is a clinical photo of the nerve. There is a piece of rubber underneath it so you can actually work, and then that rubber is sutured to the lingual tissue. So here, this is under microscopic view of the inferior alveolar nerve. You can see our lateral windows. You can see our corticotomy here and how the nerve's exposed. These are just nerve hooks. And this photo I really like, because what you're going to see here is, you're going to see a spot on the nerve. This is something that I actually caught because it was hard to tell. When you look at this nerve, you don't see a lot of injury, but you do see this spot. So my attending and I decided that it might have been the Surgicel that they had placed due to the brisk bleeding, and that Surgicel had actually damaged part of the nerve. So this is very fascinating to see. So this is where we did our external neurolysis, where we just excised or incised part of the nerve there. Anytime you remove tissue, you do have to send it off to pathology. And this is the graph that we use. Unfortunately, I'm not getting paid by them. It'd be nice to have my student loans paid off, maybe sometime soon. But this is the process nerve allograft. So from Avance. And what we do is we just basically connect the two ends, or fill the gap. So here, this is where we use non-resorbable sutures. Again, this is all done under microscope, which is insane. This just shows you how talented my attending is at this and how delicate the procedure is. And then this is him suturing the other end. And then this is just a beautiful photograph through the microscope showing the nice connection of the allograft to the inferior alveolar nerve. What we do next is interesting. There's a thing called a nerve connector, and this is actually made of porcine. What it does is it wraps around the nerve as a protection. So this is it there. So imagine you have this sheet that wraps around the nerve or the allograft that you just sutured, and then you do suture the nerve connector there. And again, anytime that you use this product, you do have to put it into the operating room, so I just added this here. So her post-operative visit, so again, a 33-year-old Caucasian female, status post-external neurolysis with Avance graft neuropathy of of the left inferior alveolar nerve. So again, we're about 4 months out. She's doing well. However, she does have some pain just from surgical pain. Physical exam, essentially benign. She does continue to have left cranial nerve 5 division 3 anesthesia that was consistent with preoperative evaluation. Her left lingual nerve is sensate, so nothing damaged there, and then incisions closed with no signs or symptoms of infection. The one thing I do want to say, and I apologize, is we took that lateral window or that buccal cortical plate off. You can put it back on. The problem is sometimes when you put it back on, you can actually compress the nerve. So a lot of times we won't put that plate back on and then just primarily close the tissue. So our assessment and plan, she's only 2 weeks out, so we're going to continue to monitor her, and then later we're going to begin another neurosensory testing regimen. So her follow-up visit, so her surgery was in July, and now we're in October, so about 3 months from surgery, but 6 months from initial insult. So her physical exam, unfortunately, the dermatome or the dermatome responsible, there's no improvement at this point. She does have lingual sensation that is intact. However, she is not having any improvement with the surgery, and that's something that we do review with them. So to finish up, these last two slides just provide papers, and what's really neat is my attending is actually on this paper, which is fantastic. So this talks about the microsurgical repair of the inferior alveolar nerve success rates and what factors actually affect the outcome. So this is a retrospective cohort study. They had 167 patients. 186 inferior alveolar nerves were repaired, so some patients actually had bilateral repair. The mean time from injury to surgery was about 10 months. And finishing up this last slide, the successful recovery was observed about 82%, which is fascinating. That's a fantastic percentage. Obviously, we would like that 100% because the quality of life is affected so much. The threshold of achieving full recovery is about 51 years. Okay, so she's 33, she's on the younger side, so which will help. The other thing that we notice in this paper is the fact that the successful outcome actually drops if you delay it 12 months after surgery. So this goes back to the importance of, as a general practitioner, if you sense something's wrong, something's probably wrong, so just immediately send them to an oral maxillofacial surgeon. We respect that much better than waiting 4, 5, 6 months. You wouldn't do that with your family, so you shouldn't do that with your patients as well. So the third part, and I'm finishing up here, the third part, or the next series, will be the lingual nerve damage and repair. So a very similar situation, however, it involves the lingual nerve. So again, thank you so much. If you all have any questions, you can contact me at my website, drmattkoepke.com. I'm all over social media. It's been amazing connecting with everyone through Implant Compare. And again, if you have any questions, please call me, text me, message me. The other thing too is, like I said in the first lecture, this is something that you could talk for 1 or 2 hours. So if this is something that you all are interested in at a conference, this could easily be made into a longer lecture series along with a Q&A. So I appreciate it, everyone. Take care. I'm going to go get some sleep since it's probably, 3:30 right now. See you later. Good morning, everyone. Dr. Matt Koepke here, talking about Part 3, lingual nerve damage and repair. Behind me again, this may look familiar. I'm still in Sydney, Australia, and it's still 3 a.m. So good morning. Hopefully everyone had an amazing weekend and a safe one as well. So thank you, Implant Compare, for making this happen again. We're finishing up this trilogy series, Rossiniu trilogy series, Part 3, lingual nerve repair. So Part 1 with nerve anatomy and damage etiology, another quick review for anyone who missed it. So sensory, so the inferior alveolar nerve is a branch of the mandibular division of the trigeminal nerve or cranial nerve 5. This provides sensation to the tongue, lower jaw, skin, and lip. There is a motor component which does supply the mylohyoid and the anterior belly of the digastric via the mylohyoid nerve. Today we're going to talk about the lingual nerve that does provide the sensation to the anterior tongue. So in regards to wisdom teeth, a lot of times this nerve is damaged because of our flap design. So here on the right hand side of the screen, where this surgeon or dental practitioner had made an incision that looks pretty medial to what we were taught in residency. Here is a more conservative approach on the right hand screen. I'm sorry, the other one was on the left hand screen. I apologize. So with this surgical incision is smaller and it's more lateral than the previous. What we were taught in residency is to do a distal buccal hockey stick incision that will prevent damage to the lingual nerve. In the center here, you can see that the flap design is what caused the lingual nerve damage here. So if we focus on this angular or distal buccal hockey stick incision, what happens is we do avoid damage to the lingual nerve. The next important thing for everyone placing implants is to stay 2 millimeters above the superior lamina of the inferior alveolar canal. So whether it's a pilot drill, whether it's your sequential implant osteotomies, you need to stay 2 millimeters above the canal. Also, what's important is there's typically a 0.5 extension on the drill. So even though you may think you're away from the canal, you may still be near it because of that extension of the actual drill bit. These are 5 common reasons why the inferior alveolar nerve could be damaged. So this medical schematic is cross-section of the mandible. The circular diagram or anatomical location there is the canal itself, and this is just showing that the nerve can be damaged by the drills itself, whether it's direct trauma, whether it's ischemia from temperatures of not using cool irrigation. The other thing that we talked about is that there's potential lidocaine or articaine toxicity to the nerve. Now, when I was trained, we never did blocks with 4% articaine or septicaine because that 4% means 40 milligrams of septicaine, whereas the 2% is 20 milligrams. So there's just a concentration difference of the anesthetic. What we also discussed is that there are studies that support both. So my general rule is I just don't provide blocks with 4% articaine or septicaine. A little bit about nerve anatomy. There are 3 layers that we like to that we use for nerve injury. So we have the epineurium, which is the outer coating. We have the perineurium, and then the endoneurium. So this is the SEDDON classification of nerve damage. You can see on the right this medical illustration. First we have neuropraxia, which all 3 of those layers are intact. However, there are some conduction deficits, but typically you will have spontaneous recovery. The second is axitomesis, where you have the endoneurium and the perineurium sheaths are intact. However, that outer coating of the epineurium has been damaged. And then neurotomesis is where all sheaths have been injured, and typically this is where you need to do surgical repair. So this is what we'll dive into part 3. This is the last part of the trilogy series on lingual nerve damage and repair. So the case report is we have a 15-year-old Caucasian female that presents for evaluation of right lingual nerve paresthesia, and she had her wisdom teeth extracted February 15th, 2015. So her extractions were done by a general practitioner, and what had occurred is she went to an outside oral maxillofacial surgeon for initial evaluation. That maxillofacial surgeon then referred her to us because my attending he specializes in microsurgical repair. So we saw her, and she continued to have no improvement since surgery. The other issue with her is that she was continually to bite her tongue because of the anesthetic. Past medical history, she's a young 15-year-old female, which is fabulous in terms of any type of surgical repair. She's going to be the best fit for healing. Past surgeries, oral surgery. Medications, none. No known drug allergies. Social history, negative ×3. So if any type of surgical repair was going to occur on her, she would be the best fit just because of her past medical history and her health status. So reviewing some of her x-rays, so this is an orthopanogram, medium value. This is diagnostic because the condyles are in the fossa. And we can see that we have 4 full bony impacted wisdom teeth. Now, the bad thing about orthopantograms or any type of imaging is you cannot see where the lingual nerve is. unlike the inferior alveolar nerve. So this film doesn't really do us justice in terms of hindsight, in terms of where the lingual nerve is. This only helps us regarding the inferior alveolar nerve. So her physical exam, no cue to stress, alert oriented ×3. Her extraoral exam, no signs or symptoms of anesthesia. She has maximal incisal opening. Her lateral excursive movements are 10 millimeters bilateral. Intraorally, great oral hygiene, well-healed extraction sites 1, 16, 17, 32. No erythema, no signs of infection. However, she does have an anesthetized portion of her right tongue. So reviewing the article, Clinical and Anatomic Observations of the Relationship of the Lingual Nerve to the Mandible, this is where they saw about a 17% chance of the lingual nerve being at the level of the alveolar crest. And so the medical illustration on the right shows us that that is the lingual nerve within the soft tissue envelope. The one thing that we need to be aware of is that in this study, they found that 62% was actually contacting the lingual plate. To me, that's a little scary, because what happens is if we extract this wisdom tooth and we perforate the lingual plate, or somehow the wisdom tooth is extracted lingually, and that thin lingual cortex is jeopardized, well, that lingual nerve, if it's intimate with that cortex, then we could have an issue. So this is what type of nerve testing you would suspect for lingual nerve. So this is obviously the mapping area for the inferior alveolar nerve, and what we just do is we would do it for the tongue. So here, this is not the patient's tongue, this was found on the internet, but for her mapping was completely anesthetic on the right, and she had normal mapping on the left. So we go through our levels of testing. So our level A testing, which is a 2-point discrimination. Again, we're going to do it on the right hand side. She's completely anesthetized, so it doesn't matter what our point of our calibers are, she's completely anesthetized. And on the left side, she shows normal testing with the calipers being 6 millimeters, and she can still decipher 2-point contact. The level B testing, this is where we use those Von Frey filaments. So for her tongue, not surprised that she's completely anesthetic on the right, and then on the left she's at a 2.44. So in terms of the nerve repair, this is when we sit down at our consultation appointment. We explain to her that because she's been anesthetized this entire time, that in terms of spontaneous repair is unlikely, and so this is where we do surgical intervention. So the date of surgery is 6 months later. So again, we're still within this time frame, but obviously the sooner she gets to us, the better. Preoperative diagnosis is trigeminal nerve injury, because the lingual nerve is a branch off the trigeminal nerve. Post-operative diagnosis, same thing. The procedure is the expiration of the right lingual nerve. External neurolysis, which means we're actually removing a portion of the lingual nerve. And then the secondary neuropathy of the right lingual nerve with allograft means that we're using a segment of allograft to then suture in the other ends. If this said primary neuropathy, what that means is we would segment the nerve and then take the two native ends and suture them together. But it's secondary because we're adding an allograft in there. So these are the two flap designs that we can choose. These flap designs are very common for the bilateral sagittal split ramus osteotomy. This is the type of dissection that we still use because we have to dissect the medial portion of the mandible to get access to the lingual nerve. This is a this is a clinical photo taken off the internet that shows the dissection. Please ignore the osteotomy. I use this photo to purely show you that The blue arrow shows you the medial portion of the mandible. The white arrow shows the lateral portion of the mandible. So with this access, we can actually start to dissect the lingual tissue to start finding the nerve. So here, this is a clinical photo showing the right dissected lingual nerve with the rubber platform underneath. This is kind of a fascinating clinical photo because I don't know a lot of providers who have seen the lingual nerve. I think some of you all have seen the inferior alveolar nerve down in the canal, but in terms of seeing the lingual nerve, this is a pretty cool photo. So this is the portion that we've resected. This is the complete section that we've resected. Again, any soft tissue that is excised, we have to give to the pathology department. That's just hospital protocol. And this is what we send. This is just the pathology pre-report, I guess, where we label the nerve tissue or the neural tissue and send it off. This is the components that we use, the same thing that we used last time by Exogen. Unfortunately, I'm not getting paid by them, but if they want to take care of my student loans, please email me. That'd be fantastic. So it's an Avance nerve graft, but then there's an AxoGuard or an Axo connector that protects everything. So this is it here. So Avance is the nerve graft. This is the processed nerve allograft that you see. Exogen does come up with components called AxoGuard or an Axo connector, which is made out of porcine. This is where we take the two native ends, we put the Avance allograft in between, we suture it with non-resorbable sutures, and then we take the porcine covering and cover everything as a protector. So this is a beautiful photograph showing the Avance allograft in between the two segments. So we're going to reapproximate everything. Then we're going to use 80, 70, 80 nylon non-resorbable sutures to hold it in place. And then what we do is that little thin coating that is over it is the actual Axo connector or AxoGuard, which is the porcine covering. And then what you do is, if you can, and this is all done under microscope, is that we try to suture even that together. So my attending, who's an expert in this field, did an amazing job. I'm just there suctioning and taking photos because this is a highly specialized procedure. So here we go. This is us removing the rubber component and in the process of closing. So what we do in terms of closing, we do close the muscle layer underneath with Vicryl, and then we do close the oral mucosa typically with Vicryl or chromic suture. So post-operatively, this is 2 weeks after the repair. We have normal post-operative healing. She does report continued anesthesia with some intermittent tingling feeling in her tongue. Her physical exam, she does have a maximal incisal opening of 25 millimeters. That's just normal post-operative swelling and inflammation. However, she has no signs or symptoms of extraoral infection. Intraorally, the surgical site is completely closed with no sutures. The lingual gingival marginal tissue that is associated with tooth number 27 because of the dissection is slightly erythematous. It's all normal. There is some hyperplastic tissue that's overlying the occlusal surface of 31. That's not surprising because of the inflammation of the tissue in our surgical dissection. Our pathology report comes back as neuroma, which is not surprising. And then our assessment and plan at the 2-week follow-up is a 15-year-old Caucasian female, presents 2 weeks status post right lingual nerve repair with excision of neuroma and allograft. And what we did during that is just review some post-operative instructions and then also reviewed the pathology report. Next appointment will be 2 months. So her follow-up visit is October 2015. Remember that she did have the surgery in August, but her initial iatrogenic injury was back in February. So she does report continued numbness, however, some intermittent tingling and burning of her tongue. Her biggest chief complaint is it's frustrating because she still can't taste food. So you can see how this damage, if we're not careful with our flap design, how this can really change someone's quality of life. That's why I'm really stressing, if you're going to extract wisdom teeth, I'm more than happy, or any other surgeon should be happy, to show you correct flap design. But if you're just extracting wisdom teeth and you have no idea of flap design, then this is a huge no-no and you're doing a terrible thing for a patient. Physical exam, benign extraorally. Intraorally, the erythematous tissue has been resolved. No signs or symptoms of infection. And then assessment and plan. So status post right lingual nerve repair with excision of neuroma and allograft. We do have minor neurosensory improvement with subjective findings of burning and tingling, which is a good sign. And then what we'll do is we'll continue to monitor and perform neurosensory testing at the next appointment. So as I finish up this lecture and this trilogy, we're going to just review another paper that my attending wrote, which is fantastic. You can find both the inferior nerve paper and the lingual nerve paper online. And if you want to email me, I can easily send those to you as an email attachment. So looking at the paper, this is a retrospective chart review. There were 222 patients that underwent lingual nerve repair. What was interesting and not surprising is the fact that the most common complication was mandibular third molar at 86%, right? Which is not surprising. That's why we have to be careful with our flap design and when we reflect our flaps and when we're using surgical handpieces so we don't perforate the lingual plate. 6.4% was from orthognathic surgery. And then the last slide here is that the mean time from surgery, from injury to surgery was about 8 to 9 months. But this is what's fascinating, is that out of the 222 patients, 201 patients, or 90%, had a positive outcome, which is fantastic. So majority of those actually had complete recovery, whereas a portion of them had recovery enough where it was useful sensory function. The unfortunate thing is that 9% had no improvement. Yes, we want that to be 100% positive outcome, 0% 0% bad outcome, but this is where we as providers need to step in, do a better job with our flap design, be more diligent in the surgery itself. So thank you everyone at Implant Compare, everyone who's watching across the globe. Again, it's 3:20 a.m. in the morning for me. You all have an amazing week, and thank you so much. Give me an email, send me an email if you want any of those papers. The other thing too is the fact that we did these 3 20-minute segments. Anyone who's interested in lecturing or conference, this could easily be another hour or 2 hours in more of a Q&A session. So thank you so much everyone. Have a great day and be safe, okay? Thanks.